Thank you, Andreas, for having me here. And do you know about Aibling? Also called Aibling. It's between Munich and Salzburg, so it's about 30, 40 miles away from Munich, or 60 kilometers. And it's a huge neurorehabilitation center. So in Germany, at least, neurorehabilitation does not take place at the university. I don't know how it's in the Netherlands or in France, or there are these hospitals in nice environments, because one thinks, okay, it would be good if the patients can just go out for walking and things like this, but basically they do not, because they are often so severely affected, not the vestibular patients, but patients after stroke or head trauma or whatsoever, that they cannot really enjoy the environment. But that's the history of it. So it just is a little bit away from Munich, the neurorehabilitation in Bavaria. So when I go here to the next slide, what we do there is a lot of training in all conditions and also technical support for gait training and everything. And concerning vestibular treatment or treatment of vestibular patients, we have a day clinic. The reason for this is that these patients are often not that severely affected, so they can go home in the evening, or they can stay in a hotel or whatsoever, and then they come back the next morning and can do the training. And what Andreas already mentioned, what can we do in treating these patients? We can give medication, we can do vestibular rehabilitation, but we also have to do counseling and education of the patients, and this is really important. And this also makes the difference compared to just doing physical therapy as an outpatient somewhere. It's extremely important that patients get an explanation for what happens with them, that they understand why they are dizzy, and that they know that they should not pay that much attention in certain situations and similar things. And that's the reason why you should do it in a structured environment to have good results in the patients. We also wrote a book about this. This is together with two ENT specialists from Germany. And that's interesting. I don't know how it is in other countries. So it's more difficult compared to using different languages like English, French, and German, just to talk between disciplines. So sometimes the disorders are completely differently defined, and so it's good to start the discussion to have common treatment approaches. What I will do now, so some of you know these disorders very well, and are working in basic science and are not knowing the disorder so well. I will show you in the most common disorders what is the treatment, the non-surgical treatment, and I'll show here what are the most common disorders. So the most common one is the positional vertigo, so the BPPV, and the triple PD, so the functional dizziness and vertigo, is also very common in the outpatient clinic in Munich or in Bad Aibling. And there are other disorders that all have, so about 10%, so vertigo, vestibular migraine, Meniere's disease, and bilateral vestibular failure, and then more so not so common disorders like, for example, vestibular paroxysmia or fistula and things like this. And this also holds true that you have only about 10 diagnoses that are common. In the emergency department, you see the gray area here are unknown diagnoses, so not made in the emergency department. This is a larger proportion. But on the other hand, you see the same disorders also occur in this situation, and they occur in all situations. And the most common one, the BPPV, and perhaps also the functional dizziness, will also happen in your families and in your neighborhood and in your environment. So I think each of you should be able to treat BPPV, because you will be the star in your family next Christmas when you make Aunt Eleni walking again, for example. And what's also interesting, So people are coming at daytimes in the emergency department, so you cannot really know what is the disorder when they come in the morning or the afternoon. But you know that these, for example, the BPPV often starts in the morning after bed rest, and they report then that they awoke this morning with dizziness. And when you look at different times of the year, then there is a certain concentration of some disorders in autumn. This is for the unilateral failure, it might be related to viral infections. For the BPPV, it might also be related by less activity of the people, but also by vitamin D a little bit. Also, even if it's proven it's not that important in this disorder. And it's not so much known why these functional disorders are also occurring after summer holidays. But it's just statistics from many thousand patients that we have seen in Großhadern. So I will do the presentation now like this. I just start with different forms of kinds of presentation. And when you look at patients that have short attacks just lasting seconds to minutes, what would be, for example, a disorder which could cause this? One would be the BPPV. This is very, very common. And the vestibular paroxysmia here is much less common. So here the BPPV is really important. And there are other disorders that also occur. Very common is the so-called orthostatic dizziness. It means just dizziness with low blood pressure. So when just standing up very fast, for example, and then having a short attack of dizziness. But this is not really vestibular. Of course, the response is vestibular, but it's when you recognize it, you just have to see that patients have enough fluid and modify the medication for the blood pressure. But the specific disorders are the BPPV and the vestibular paroxysmia that are relatively common. The perilimb fistula or the descent syndrome are less common. And the functional dizziness usually causes sustained, long-standing problems. But sometimes these patients also report while walking, for example, short side steps or something, that they are irritated, and then they can also report such short attacks. So the typical presentation of such an positional vertigo would be: I woke up in the morning, a severe attack of vertigo, and afterwards, whenever I moved the head, when I looked up to the ceiling or something, there was a spinning vertigo. So when you hear something like this is this very common BPPV. So always triggered by head movements and not at rest. And then you know this should be disorder. In all these vestibular disorders, there are classifications now from the Barani Society where you can read it up. And then what you do is you move the head in the plane of the affected semicircular canal. Most commonly, it's the posterior semicircular canal. And you cannot remove the head from the rest of the body. So you have just to find out how you can move the body. So you can sit the patient, turn the head to the right, for example, and lay down to the left side. Then you have this left posterior semicircular canal in the plane of the movement, or you move the head to the other direction and go backward, the classical Dix-Hallpike maneuver, and then you again move the right on the right plane of one of the semicircular canals. And then, for example, such a nystagmus in typical cases, and you know this is the disorder, you made a diagnosis, then you have to explain to the patient what it is and what to do. And then I cannot go into details. There are different liberatory maneuvers. And for the posterior canal, there's the Semon or Semon Plus and the Aibling maneuver. And for the horizontal canal, there are other maneuvers. And then you have to do this with the patient, and the patient can do this by themselves. So they learn how to do this the next morning. And usually they are free of symptoms within a few days. They have to know that they will have a little bit of instability while standing or walking. and this will go away, and then there's a high risk of recurrence in the future. But if patients know that this can happen, they also know how to treat it. And this is so common that you should look up one of these maneuvers because you will need it definitely in your environment or by yourself in the near future, or you already used it perhaps in the past. You do not need medication in this disorder. It might be that the spinning vertigo is so severe that the patient cannot do the exercises recommended, and then they need some vestibular suppressants before they can do the maneuver. And this is not only true for this disorder, so it's always the same kind of medication you can use. And it's always true that you should not do this for a long time, so you should not suppress the vestibular symptoms for a long time, so this will not help the patients. But in the case of the BPPV, you can do this, then do the maneuvers, and as soon as the patient is free of symptoms or better, then you can stop the medication. There was a long discussion about vitamin D, if low levels of vitamin D, subnormal values in the blood, are a reason for developing BPPV. There are studies in both directions. So at least in wintertime, when the values are too low, you can supplement it. This is something you can do. Otherwise, it's important that patients move as normal as possible and do not prevent anything. So there are some patients that say, I never lay flat again, and so they kind of conserve the symptoms for many months and years. As long as they move normally, they can also they know when it happens again, and they can do the treatment again. The other short attack, the vestibular paroxysmia. These are short attacks also occurring at rest. So the definition here from the Barani Society, many attacks, short duration, less than 1 minute, and response to treatment. This is unusual that it's defined by the response to treatment. So it's caused, this disorder is caused by cross compression between arteries and the vestibular cochlear nerve. And there's a transition zone between central and peripheral myelin, here shown in yellow. This is about 1 centimeter at the nerve before it enters the brainstem. And when there's a cross compression from the artery, these short attacks can happen. And then you can give sodium channel blocking medication, and you can stop the attacks. And usually it works well in patients that have, let's say, 10, 20, 50 attacks per day. You just give the medication, and then you see the next few days, they only have 5 or no attacks anymore. But it's extremely difficult in patients that do have 1 attack every 4 weeks to do this treatment. There are different drugs you can use. Carbamazepine, for example, or oxcarbazepine are quite old drugs with a lot of side effects, but they work quite fast. And nowadays, often lacosamide is used, so it doesn't matter which one. You just have to explain the patient. These also cause dizziness, but another form of dizziness. So they make a kind of lightheadedness or ataxia, but the attacks should disappear. And when this happened, then you can discuss with the patient if they should continue to take the medication or not. It's also possible to do surgery, which is rarely needed. So usually it's medication for a few months, and then you are free of these symptoms. So the take-home message for these short attacks in BPPV, you need these maneuvers, but usually no drugs. And for the vestibular paroxysmia, so short attacks without head movements, you need drugs and nothing else, and sometimes surgery. And you can see this cross compressions in MRI, but it's more important to diagnose it and then to start treatment to see if it responds. Any questions to these short attacks? Otherwise, we go to longer.
Yeah. Just a short question. So there are some pathologists that tell us that the beta blocker for vestibular paroxysmia. So propranolol or
Yeah, it's a treatment for migraine, prophylactic treatment, and you can potentially, as the attacks of migraine can on one side be very short, and it was a long discussion in the Barani definition about the vestibular paroxysmia, how long these attacks are allowed to be. And I think in some places, we have also one place in Germany where every single patient gets the diagnosis of vestibular paroxysmia. There are some places where it's allowed that the attacks last for 20 minutes or something. I think that's more or less the effect when you have this overlap with the migraine. So usually you should really use these sodium channel blocking substances. And for me, and it's also the definition, at least for the most probable ones, these attacks should be seconds, and definitely less than 1 minute. So longer episodes, let's say 2 hours. What can it be? It could be Meniere's disease, or it could be vestibular migraine, basically. So these are the common disorders. It can also be ischemia, stroke, short attacks, but it's very unlikely that this happens in the same way again and again. And there's the episodic ataxia, in particular type 2, that can also cause attacks again and again, but it's very easy to diagnose because you also see between attacks central motor abnormalities, downbeating nystagmus, for example, as you have seen it before. And it's rare, and it's in the family, it's inherited in the family, so it's not difficult to diagnose. The challenge is always to say which one of these two common disorders takes place. Is it Meniere's disease, or is it vestibular migraine? In the situation where your patient reports, for example, I had several attacks lasting 4 hours, and then they either report, as stated here, it always started with pressure in the right ear or hearing loss or something, then it's Meniere's disease, or they have just migraine and light, fear of light and loud noises and things like this, then it's migraine, Meniere's disease. So here's the definition again for Meniere's disease. So these attacks are longer compared to the vestibular paroxysmia, up to 12 hours, and they have this hearing loss going along with it. And it's known that there is too much endolymphatic fluid, but it's not really known why this happens in a single patient. And there are probably many ways to develop the same kind of disorder, many reasons that just start in different times of the year. And you can see this endolymphatic hydrops in MRI if you want, but it's more important that you have the right history of the patient. And then you do the management. And then I can summarize the management for all kinds of treatment we have. The evidence is low. And we still believe that the beta-histine that was already mentioned by Andreas helps. And there are studies needed, there are negative studies. And so you can find experts that just tell you, okay, there are some studies proving that it's not helping at all and you should not use it anymore. And others that will say, okay, the dosage was too low, you have to combine it with the MAO-B inhibitors and it will work. And my personal experience would also be, patients get better. We know that there's a huge placebo effect in these disorders. And so it's difficult to prove on a single case, but it's quite well tolerated. And so many patients still get beta-histine. There are other ways to treat it, as mentioned here. And it's the easiest way to start with the beta-histine. It's very, so it works very well to use gentamicin and destroy hair cells, but you destroy hair cells in this way. And so you have some loss of function, but at least this is very good in patients that have many attacks and falls and fractures of their bones or whatsoever, then this works very well and very fast. The surgery also has a very, very low evidence. So Andreas already mentioned that it might be good to combine the beta-histine with the MAO-B inhibitor to have more drug and more substance in the blood, and then also working at the inner ear and improving the blood supply in the way that this high pressure decreases very slowly. So the patients have to take this medication for many weeks and months, and then they get less attacks. And so probably it might help if you really get a substance to the right place. And here on the right side, you see other ways to treat the Meniere's disease. So in vestibular rehabilitation training, you can use it after attacks. You can also use it as a pre-rehabilitation before do any surgery or something, any intervention to improve the situation. But between attacks, patients should be quite free of pretty free of symptoms, and so they do not need training in between. They should not develop functional dizziness, and the risk of developing such functional dizziness in particular occurs when you concentrate very much on your symptoms, and so it's not so good to do training all the time in this situation. And the other disorder with attacks lasting for hours is migraine, vestibular migraine. So the definition is attacks between 5 minutes and 72 hours. And the important thing is these patients should have migraine. As you know, some of you in the room will have headache migraine. It affects 15 to 20% of the population. So it's very common. And you can make the diagnosis if you just have somebody who also reports that he or she had other migraine attacks in the past. That's sometimes difficult in childhood because just children start having vertigo attacks, for example, and never had headache. Then you just have to start treatment at any point. And when you look at the patients, you see that it's a central disorder, the migraine. So Meniere's disease happens in the inner ear. Migraine is a central disorder. And so you have sometimes a little bit of central oculomotor signs, very subtle signs also in children and adolescents. And there are many patients that are a little bit between Meniere's disease and migraine, and sometimes difficult to make the diagnosis. But one is central, one is peripheral, and one you have migraine symptoms, and the other one ear symptoms. And the treatment differs, and you have to decide which one to start. And migraine is also a disorder where you need drugs, prophylactic drugs, so it's not so useful to treat a single attack. Usually patients take something prophylactic, but before you start drugs, do everything what can be done without drugs. And it's known for migraine that it's very effective to do regular sports at least 3 times a week for 30 minutes to reduce stress and to learn techniques or to have a certain relaxation and to have enough fluid and enough sleep. This works. And if this is not enough, then patients take this medication. There are several mentioned here. There are also new medications like these CGRP antibodies and antagonists, the GEPANs, that can be used as prophylactic treatment. But you have to make the diagnosis first. So in these repeated attacks, you Meniere's disease, you see what the patient needs. Often you start with beta-histine, and for migraine you start without drugs, and then if needed, if there are many attacks, you just give the patient also the prophylactic drugs. So now, if somebody gets a singular attack starting at some point, never happened before, it lasts for a few days, what can it be? It can be acute unilateral failure or stroke. This is the most important question. Is this peripheral here, or is the central, which means stroke, for example, in the brainstem or in the cerebellum? And it can also be other central lesions, for example, in multiple sclerosis or something, but this is less common, that it really presents as more or less isolated vertigo and dizziness. So in this situation, you have to see, it can be the first attack of Meniere's disease as well, but if not, then you have to decide if is it peripheral or not. On patients' report, they have the severe spinning vertigo, rotatory vertigo, vomiting, nausea, not able to walk, very severely affected. And in this situation, you have to know, is it central or peripheral? The definition here is that it should last at least for 24 hours. In this Barani paper, there are also forms, or is the possibility to make the diagnosis earlier, to include patients in clinical studies. But in typical cases, you should have it for several days, and so at least for 24 hours. And you should be able to see this deficit of the vestibular ocular reflex by clinical examination, by video head impulse test, by caloric testing or something. And then you know this could be this acute unilateral failure. So you have the acute unilateral vestibulopathy causing an acute vestibular syndrome, which always presents in a similar way as just mentioned. You have spontaneous nystagmus. Patients are not being able to walk and fall to one side. And here we have really very good evidence for rehabilitation training. So these patients should start to do exercises as fast as possible, which means that they already, when they are not able to stand and walk, could start to do combined head and eye movements, for example, and then they should get up as fast as possible. This will cause that they improve within a few days. If they do not do like this, just stay in bed for several days, then it will just prolong the disorder, and the risk of developing a secondary psychogenic functional dizziness also increases. So yes, as already mentioned, moderate to strong evidence, and the odds ratio is 2.7, which is quite high. Just looked up yesterday for another talk, the evidence for robot-assisted gait training, which decreased over the years. The more studies we have, the less evidence. It's 1.6 or something. So this is quite good evidence that really this training should be done. So this review here is for the unilateral peripheral vestibular dysfunction that we just mentioned. And what is done in vestibular rehabilitation, there's on one side this eye-head coordination, so combined movements of eye and head. It's not useful just to do eye movements, for example. You always have to do training of the vestibular ocular reflex. So this combination, you should do exercises for postural control and coordination, and you should also do exercises for cognitive postural interaction, so dual tasking, doing two different things at the same time, distraction by a second task that you have to do. So this will help and should be adapted to the single patient, so it should be really done at the personal limit, so it should be difficult for the patient, difficult enough that he really gets dizzy, and then it should be done every day, at least, let's say, 15 to 20 minutes, which does not sound a lot, but if you have to do this at home each day, then the majority of patients does not do it sufficiently. And so it's very important to counsel the patient that he has to do it, and it can be supported, of course, by motivational apps and things like this. And then you also give medication again when you have this peripheral loss, usually steroids. The pathophysiology of the disorder is probably inflammation induced by viral infection or by reactivation of herpes virus. And the treatment is immune suppression by steroids. And there's also moderate evidence that this really works. And this should be done. There are different ways of application. But the important thing is early mobilization. And now it can also be a stroke in the same situation. So in this peripheral disorder, you see here, for example, a patient that where the head impulse test is done, and you see that when the head is turned to the left side, there's no corrective saccade, and when the head then is turned to the right side, then you see this eye movement, and so there's a finding which would be fitting well to this peripheral vestibular failure. And in central disorders, you often also have this skew deviation that one eye is higher than the other, but the same kind of spontaneous nystagmus. And so you can distinguish this by just doing some clinical tests and looking for any oculomotor abnormalities that should not be present in this peripheral disorder, where you just have the spontaneous nystagmus with certain characteristics. But as soon as you also have, for example, gaze-evoked nystagmus to the other direction, or normal head impulse test in situations with severe spinning vertigo, then there's a high probability that it is central. And if you have risk factors for central disorders like high blood pressure, increased age and things like this, it's also very likely. And then you should be MRI scanning of the brain, for example. There is also this definition of vascular vertigo. You see that there's, again, a definition of 24 hours and more. Of course, there are also short attacks that can happen. But in the situation where you see also a lesion in the MRI scan, you often have longer durations, very similar to the peripheral one. And then you have to do a very exact clinical examination to see if there are any additional signs. And the treatment is the same as for any other stroke. And of course, you also do vestibular rehabilitation therapy, even there's less evidence. So there is not such a Cochrane review showing that this works, but it should work in the same way as for the peripheral lesions. So you can do the same, but it's still important that you distinguish between central and peripheral, because the treatment and the prophylactic treatment to prevent other strokes in the future is completely different. So you have to know this, even if you do balance training in both disorders. So when we summarize these singular episodes in the peripheral acute unilateral vestibulopathy, patients have to do early exercises and get steroids. And in stroke, they get another treatment. And it has to be identified to do the normal workup for stroke. And then they also get exercises and will also improve. There's also good evidence also from a study that one of the students of Andreas did, that there's a quite good outcome of the patients. They usually improve a lot. Okay, so now, last but not least, the long-standing sustained vertigo and dizziness lasting for months and years. What can it be? It can be triple PD, it can be bilateral vestibulopathy, or any other sensory deficit, for example, polyneuropathy also, so peripheral neuropathy, the functional dizziness. It can also be neurodegeneration. So many patients present when they just develop Parkinson's disease, or they have this downbeat nystagmus that I've seen in Andreas' presentation. Also, many people, older subjects being 80 or 90 years of age, have dizziness. They usually have a combination between low vision, a little bit of loss of function in their vestibular system, peripheral neuropathy, anxiety, and all this leads to long-standing symptoms. But also in these patients, it's important to identify the vestibular deficit and to treat this specifically. So, for example, the typical presentation of a patient with a bilateral vestibulopathy, So instability while walking, worse in darkness, and then these oscillopsia, these movements of the environment that these patients sometimes or in many cases report. And there's also a definition again of the disorder. And there's also in the definition that it's worse in darkness, for example. It's only, these patients only have symptoms when moving, when standing, when walking, not when sitting somewhere. So if somebody sits in front of you and tells you, I'm dizzy all the time, then there is at least a functional component, which of course often happens at the same time. The patients have peripheral loss and a functional worsening of the situation, which can happen. And then you have these bilateral pathological head impulses as shown here with these saccades on both sides. And you have these oscillopsia, which is not shown here. Oh, it doesn't matter. So it looks as if somebody would walk around with the camera not stabilized. And so these patients have to stop to read signs and things like this. So and here the treatment again, of course, is training, vestibular rehabilitation training, lifelong training, more or less. Patients often say, oh, I did this for 2 weeks and now I'm not better and I stopped. And so it does not work. So you really have to do long time training. The pathophysiology is different. In many cases, we do not know exactly what caused the bilateral vestibulopathy. It might be ototoxic medication like gentamicin for heart diseases and inflammation, and it can also be inherited. There are a lot of patients with positive findings in this RFC1 gene that often have this combination with cerebellar symptoms and peripheral neuropathy, the so-called canvas syndrome. But many of these only bilateral vestibular patients also have this inherited component. And then they have to do the training. So vestibular rehabilitation with and without biofeedback, neuromodulation, technical support. You will hear a lot about the technical possibilities in the next talks. And you also should do the training all the time. You see those later. And there's also evidence what you should do. As I mentioned, eye movements alone will not help. This is a really good guideline from the not only US right now, but worldwide physical therapists that summarized for what kind of exercises there's evidence and for what kind of exercises there is no evidence. And so it's again for these peripheral lesions where the evidence is high, but you can also use this for central lesions. And then there is written down what you can do. And it's important also to explain everything to the patient. And it's also documented here what you should not do. So it's a very helpful thing. And the last disorder is the functional dizziness. Very, very common. Triple PD named in nowadays, but functional is a little bit of neutral naming that can also be used very well, in my opinion, to explain it to the patient, because they have symptoms that are real, and you have to explain to them how this happens and that they do not have to go to a psychiatric department immediately, but they just have to go to an automatic way of balance control again. And so you can do the diagnosis easily. It's more common in young subject, if you've seen here, as you see here on the left side. So in younger patients, it's common. In older patients, it's less common, but it still happens. And then it's an open question how much physical therapy you should make in these patients. So they need this education and counseling. And there is evidence for a combined therapy of psychological and physical support, but they should not concentrate too much on their balance. They should not stand on one leg all the time and think, is this okay or not? They should just get more confidence that this works and should just in this way do exercises, but also to be active and not they usually do not really need to train difficult things because they already can do this. There is this vicious that it gets worse whenever these patients concentrate on their balance and they see, okay, I have a little bit of sway, and then they try to contract their muscles, and then it becomes even worse because they need this normal sway to be flexible in certain situations. And so the explanation and the education is really important. You can also give drugs to these patients. There's again low evidence to do these, to use, for example, these serotonin reuptake inhibitors that we often give. I'm personally quite convinced that there's also a high placebo effect. So when you explain to the patient, this will help when I give you 5 milligrams of citalopram or something, then it often helps. But I'm not sure if, so I'm sure that if you are not explaining to the patient what will happen, then it will never help. When you explain it well, it will help. And some of them also have anxiety disorders and it will help more. But yeah, again, not a very high evidence for this treatment. So training for bilateral vestibulopathy, counseling for these functional patients together with brain training. And there are more drugs. The 4-aminopyridine was mentioned, which helps in part of the patients with downbeat nystagmus, and also helps to prevent attacks in episodic ataxia type 2, for example. It's quite specific, and you can do this. And also these patients need training in between. You can use apps and telerehabilitation to improve the compliance of the patient. We're just starting one study with Arameldron together to use her device to adapt the training to the single patient, and also to have a certain monitoring of what the patients are really doing, because they are wearing one of these sensors, and then you know if they are moving or not. And so there's something happening in the field. And this is our hospital in Bad Aibling. You are welcome to visit us whenever you are between Munich and Salzburg. And I thank you very much for your attention. Thank you.